So this is very key. Maternal physiological changes in pregnancy. What are the normal, we can say maternal normal changes in pregnancy? What do we expect to change? What do we expect to be the changes? It's not going to be normal. The mother is carrying the baby and the baby is foreign. The baby needs food, needs an extra bread, needs an extra blood, needs an extra um, fluids. The baby has more kilos. The mother is not going to be the same. There are many changes that are gonna happen. Um, this is designed to enable uh, us to integrate the scientific basis of why the mother changes anatomically and physiologically during pregnancy. So it might happen with the disease process, but when we know and appreciate the normal changes, it can be easier for us to um, alienate it from the abnormal and then diagnose and treat and um, all these. So at the end of the study, we need to know the changes in anatomy and physiology, endocrine, metabolic, gastrointestinal, urinary system, hematological, cardiovascular, respiratory, the diagnosis and treatment of any extreme changes that is not within the expected range. So technically speaking, the mother is affected in every other system that you know. We have almost 11, 12 systems in the human body. But when you speak clinically, they are around 6. So you speak about musculoskeletal, you speak about gastrointestinal, you speak about genitourinary system, you speak about cardiovascular because scholars put the hematological changes under cardiovascular. Then you speak about the central nervous system. Then you speak about the respiratory system. All these systems are affected during pregnancy, but the key things are here. But every system, clinically speaking, we have the 6 systems, and those are affected. None is left out. So to begin with, we can the anatomical and physiological changes and biochemical changes nearly every system, as we've said. Let us speak about the genitourinary system. On the genitoury, what does uh, pregnancy affect? How does it affect it? The uterus, of course, it enlarges. And at term, the uterus is about 35 centimeters long, 23 centimeters in diameter, and it weighs around 1 kilo. What was the change? In contrast, in non-pregnant women, it weighs 65 grams, very small. We have just added 935 grams. It measures 7.5 by 7. It has changes by 35 by 23. That's quite a lot. During pregnancy, the uterus is adapted to contain the growth or the growing fetus and placenta. It needs to grow. So there's development of the residual. Of course, we're going to do this. There's hypertrophy and hyperplasia of the muscles. So the greatest thing that happens is hyperplasia, and then hypertrophy begin or comes later. So the greatest contribution to the uterus growth and gain is hyperplasia and then hypertrophy. There is increased vascularity. There's formation of the lower segment and softening of the cervix. Higa side, we've spoken about it in diagnosis of normal pregnancy. So the myometrium during pregnancy is caused by 2 factors. There is hormonal and there is distension. So the growth is brought about by the action of estrogen and progesterone. So occurring of these during ectopic pregnancy, when the embryo is outside the uterus, we don't expect it to enlarge so much. Later, the fetus and the placenta becomes large. The distension of the uterus provides a further stimulus to growth. The blood supply to the uterus is greatly increased. Remember, the sign that you can hear the root of the uterine artery is in the broad ligament, just below the ureter. Remember that anatomy. And then the cervix, it becomes softer because of increased vascularity. We've spoken about this, the Higa sign. There is also increase in glandular spaces. When you inspect it, it's purple in color. This is the Higa sign. And the glands are distended with mucus. This is the effect of progesterone. It becomes elongated until the end of pregnancy when effacement commences. We're going to do normal labor. We're going to discuss about the Bishop's. Then the vagina and the vulva. There is increased vascularity. This affects the walls of the vagina. They become purple in color. The vagina walls become softened. This one is Chadwick sign. We've spoken about it. The water transduction that normally occurs through the vaginal wall. This is increased in pregnancy, so that the total discharge from the vagina is increased. So the vagina secretion is acidic in reaction, and in some protection, it has some protection against ascending infection. As pregnancy advances, the vulva shares in the increased vascularity and shows some swelling in consequence. Sometimes we can have varicosities, vulvar varicosities. What about the breasts? So when you can look at our approach, we're just looking at from where the baby is outside. We began with the uterus, we've come to the cervix, we've come to the vagina, we've spoken about the vulva. Now we're outside here, we are on the breasts. So there's the estrogen increases. All the secretion is about progesterone. All the enlargements is about estrogen. Don't forget. So the amount that causes thickening of the skin of the nipple, and then there's branching of the underlying ducts. The progesterone causes proliferation of the glandular epithelium. This is in preparation for breastfeeding. The breast becomes a little tender. Remember the changes in pregnancy? The patient often describes as pricking sensation in them. The increased blood supply is shown by a very obvious network of veins under the skin. The volume is increased by 200 mils, and the increase is about 1/3. 12th week of pregnancy, the glands begin to secrete an almost clear fluid. So in pregnancy, it's almost normal when you see secretion is clear and there's something tender. Toward the end of pregnancy, the secretion of yellowish, copious secretion is colostrum, rich in proteins. The nipple becomes larger and more readily erectile. The areola becomes pigmented and persists as a permanent change. Don't forget this. This change is permanently there. The skin around the nipple becomes dark and it's permanent. The stretching of the skin over the breast may produce striae like those which occur in the abdomen. Those changes are interesting. So you need to know it enlarges by 1/3, a volume of around 200. And then there's darkening of the areola. And then there is some striae like those in the abdomen. Let us speak about the abdominal wall. It is stretched. The muscles are stretched. Around the umbilicus, it might become flattened out. It even protrudes. So you see the umbilicus protruding because of overstretching and distension. It may cause the formation of stria gravidarum. They appear as curved lines, which may also be seen on the loins or the thigh, and sometimes on the breasts. Pigmentation of the line from the pubis to the umbilical is called linear nigra, may be seen, especially in dark-skinned women, and may persist in part after the pregnancy. This is not mostly permanent, we can say semi-permanent. And then we can speak about the pelvic joints. This is the musculoskeletal. Remember, we've spoken about every system is generally affected. Softening and slight relaxation of the ligament of the sacroiliac, the sacrum and the ilium. There are ligaments joining these two bones. The joints there, they relax. We have a hormone called relaxin, is responsible for this. Symphysis pubis and the mobility of these joints is slightly increased in pregnancy. And then weight, this very high, don't forget, the body weight increases during pregnancy. So the average is 12.5. The total gain varies between 7 to 17 kilos in normal cases, averagely 12.5. So 7 to 17 kilos is normal. An average of 12.5 is okay. After the 12th week, the average normal gain is about 0.35 to 0.45 kilos a week. High yield, don't forget. The endocrine changes, placenta hormones and proteins influence ovarian and pituitary function. Remember, we don't have, we have increased estrogen and progesterone. Therefore, we know that there is a negative feedback. We're not going to have gonadotropic hormone, the luteinizing hormone, the follicle stimulating hormone. It's gonna not to be produced. So all these are going to maintain the decidual. The growth of the myometrium increases the vascularity of the whole genital tract, causes proliferation in the breasts, and this we've spoken about estrogen and progesterone. These substances have secondary effects. The retention of water in the body. They are steroids. Estrogen and progesterone are steroids. So there's retention of water, there's relaxation of smooth muscles, and there's relaxation of pelvic ligament. Don't forget this. Then there's increase in human chorionic gonadotropin hormone in large quantities are present in blood and urine, and high concentrations of these substances prolong the lifespan of the corpus luteum. The corpus luteum also continue to produce estrogen and progesterone to maintain the uterus until the output of estrogen and progesterone from the placenta rises. The blood progesterone levels rises during pregnancy. Estrogen and progesterone maintain the decidual of pregnancy. It causes growth and hyperemia of the uterus and lower genital tract. Don't forget this. The breasts as well. We have inhibition of human placental lactogen and prolactin. This is the effect of estrogen. The decidual, that's why during birth, estrogen is withdrawn and prolactin increases. This is a hormone that is responsible for breastfeeding. We're going to speak about this endocrinology in pregnancy. The decidual in turn increases the rate of synthesis of prostaglandins and secretory proteins. Don't forget that. So there's increase in estrogen, there's increase in progesterone. And then, of course, towards the 20th and from the 20th week of pregnancy to 40th week, we're not going to have increased levels of human chorionic gonadotropic hormone. It's going to decrease and maintain at a certain level. Thyroid gland is slightly enlarged during you have euthyroidism. So you're going to realize that women or mothers are going to have euthyroid goiter because of increased of this gland. And then we have um, increased concentration of adrenal hormones in both the gland, the blood, and the uterine. Increased secretion of glucocorticoids and mineralocorticoid, aldosterone. So what happens in metabolism? The fetus requires oxygen and food substances. In pregnancy, the total need of calories is increased by 80,000 kilocalories. And the basal metabolic rate, of course, during pregnancy increases between 10 to 25%. Free thyroxine levels in blood are normal, slightly reduced. High protein intake, extra requirement 900 grams. There's need of 3.5 kilo desired of lipids. There's increased need of iron and calcium, particularly in the last trimester when the fetal uptake is greatest. Don't forget this. Gastrointestinal tract during pregnancy, there's nausea and morning sickness. This begins at the sixth week. That's first. When someone tells you I've missed my period, at that time when they're coming, they already have morning sickness. Stop spontaneously before 14th week. Appetite and thirst increases during pregnancy. There's some minor upset of digestion, relaxation effect of progesterone on smooth muscles. Sometimes you can have heartburn. Gastric or intestinal distension, especially early pregnancy. Heartburn, there is an increase in fundal height. There's pushing of the gastric contents by the uterus. But again, we have the relaxation effect of the sphincter, the cardiac sphincter of the stomach by the estrogen. And hiatus hernia can be your differential. Emptying time of the stomach is prolonged because there's all that relaxation of the smooth muscle. There's no contraction. Gastric acidity is often reduced, and peptic ulcer almost invariably becomes the present during pregnancy. Constipation is common, we've said, the relaxation of the smooth muscles, though the emptying time is prolonged. Genitourinary system, we've spoken about the genital part of the urinary system. There's progressive increase in glomerular filtration, GFR increases. Renal plasma flow increases. There is a fall in plasma creatinine level because of increase in GFR. There's increase in micturition. This one we've said begins faster. The first 12 weeks, when enlarging, is still in the pelvic. Progressive dilatation of the renal pelvis also occurs here. The total blood volume is increased. This is cardiovascular changes by about 30%. So there's increase in total number and volume of cells, red blood cells specifically 20%. The plasma volume increases about 50%. Red cell count of 4 million per millimeter cubic. Hemoglobin concentration of 11 grams per 100 ml of blood is accepted, and this should be the lower margin. Leukocytosis is often observed. Platelet count is normally unchanged. Erythrocyte sedimentation, ESR, is normal. Cardiovascular changes usually combined with hematological changes. The output increases from 4.5 to 6 liters. Systolic blood pressure is unaltered. Diastolic blood pressure is reduced in the first and second trimester. The pulse rate rises between 8 and 16 beats per minute. Don't forget. Systolic, normal. Diastolic, decrease a little bit, first and second trimester, returning to normal, to non-pregnant levels by term. And then pulse increases. This is compensatory. The heart is displaced outwards and electrical axis is altered. So when you're doing a physical exam, the apex beat it should be almost on the anterior um, anterior axillary line. Pulmonary ventilation is increased by about 40%. There is an increase in tidal volume. Oxygen requirement increases by about 20%. Hyperventilation leads to a fall in partial pressures of CO2. So you have something called alkalosis. The low partial pressures of CO2 gives rise to sensation of dyspnea, which may be accentuated by the elevation of the diaphragm. The fetal head engagement in the pelvis in late pregnancy, the breathlessness also diminishes. So these are the changes in respiratory changes. But in the skin, of course, we've spoken about strigravidarum and linea nigra of the abdomen and the primary and secondary areoli of the breast. Pigmentation also occurs on the face, mainly as irregularly shaped brown patches on the forehead or the cheeks. They are called chloasma. Palmar erythema, spider ivy also occurs. They are caused by increased estrogen levels and disappear after pregnancy. Changes in immune uh, activity. The immunological changes in pregnancy include 30% increase in neutrophils, decrease in T helper cells, slight reduction in immunoglobulin G. Yes, up to this end, until we meet next, we see each other again.